going to open us up with karakia and get into our webinar today. Tū taua mai I runga, tū taua mai I raro, tū taua mai E waho, tū taua mai I roto, kia tau ai te Māori tū, te Māori ora, ki te katoa, haumi e, hui e, tai pie. Welcome to the third and final session of the three-part AI in Primary Care webinar series that the Primary Care AI Working Group, what a mouthful that is, have put on for you all over the last few months. My name is Jess, I'm the CEO of Collaborative Aotearoa, and I am also the chair of the Primary Care AI and Primary Care Working Group. It's a pleasure to have you back. For those that have made it to round 3 and have done 3 for 3, go you. That's incredible. For those that are just joining us for the last part of this session or series, today we're going to be talking about navigating ethics, risks, and workforce readiness. We're going to explore some challenges and opportunities along with strategies to build an AI-ready workforce while enhancing patient care. This session is really perfect for healthcare professionals, administrators navigating the evolving AI landscape. So a reminder, if you've not seen session 1 and 2, they're on the Collaborative Aotearoa YouTube page, so you can jump on there and you can see actually years and years, nearly a whole decade of webinars that we've been pushing out for this sector. If you are wanting some CME points through the college, you can do that as well. We are a CME provider, so you're able to gain your points that way. And this is aimed to be a Q&A today. So we are wanting to have lots of involvement from the audience and those that are joining us. So please do use the Q&A function, jump in, ask all the questions in the world, and we will do our best to kind of get through them as we go through this session. So welcoming our panel to you today, we've got Dr. Samantha King, who is a GP and medical legal consultant for MPS. We've got John Heary's back again. He's also on the Primary Care Working Group and is the Innovation Data and Digital Lead at Te Whatu Ora. And we've got Igna Hunter, who's an Associate Professor at Massey University, and Rochelle Stiles, who's a consultant in bioethics and lawyer. So we've got a pretty stacked panel for you today with lots of different perspectives, lots of different views, and hopefully some good agreement maybe between the panel, and I'm sure some healthy disagreement as well. So we'll get through that as we start to work through the session today. We're going to open up with a quick presentation from Rochelle. She's got about 10 minutes. She's going to share us. You'd think Igna would be doing that, being the professor in the room, but we've got Rochelle jumping into the lecture today to take us through a few key points and kind of set the scene for the webinar today. And then we will get through to a few preloaded questions, and then we'll go straight to the Q&A. So do feel free to start putting your questions in there now or as Rochelle is sharing with us. But I'll hand to you first, Rochelle.
Thank you very much, Jess. Gosh, I hope Inga isn't going to give me a grade at the end of this. Okay, so I'm just going to share content. So I'm pressing the share button, and so tēnā tātou katoa. I'm really grateful to have this opportunity to share my perspective, which comes from life originally as a litigation lawyer and then post a midlife crisis. I studied ethics and did a Master of Bioethics. So just as a quick side note, this image that you can see there is not particularly safe or reliable. That was a prompt into Bing for co-pilots, and you can see we've got 2 white males there. It took several more prompts to get a female in there, and different ethnicities. Right, so moving on then. My question, are they safe and reliable in primary care, needs to be considered against the Code of Patient Consumer Rights, which provides that consumers have the right to have services provided with reasonable care and skill and that comply with the relevant legal, professional, ethical, and other relevant standards. So we need to keep that in mind throughout our discussion today. And I would like it during this presentation to have a look at the potential benefits or the advantages and the risks of harm of using AI scribes. Oops, we're going backwards. That's not helpful. So looking at the claimed potential benefits, I think these have been well traversed in previous webinars. So we don't need to focus on those too much just now. I was lucky enough to participate in a survey on the use of AI scribes in primary care with Professor Ballantyne Dowell Stubbe. It's currently unpublished, but it was undertaken in February and March this year. About 197 respondents, 88% of whom were GPs, 40% had experience with AI scribes, and 80% thought that they were helpful or very helpful, identifying the benefits as reduced multitasking, saved time, improved rapport with patients. And then a slightly lesser known benefit that Heidi has introduced to us through its marketing, that it's like you but less gorgeous. So there you go. An interesting study done in America teased out some of the metrics that we might think about when we talk about what is the quality of the notes that these AI scribes produce. And you can see them there on that radar plot, with the results that there was a high level of performance across all those metrics, and they resulted in high quality but not perfect notes. I've tried to find out which AI scribe they used, but I haven't been able to do so yet. And also I think it was across probably tertiary care and not so much primary care. So we just need to take into account those potential limitations. The Health and Disability Commissioner has expressed pleasure that a doctor who came before him had improved his clinical documentation by using an AI scribe, and also reminded people in his decision that the good medical practice standards clearly point out that it's the responsibility of practitioners to keep clear and accurate patient records, and that they should be written at the same time as the events or as soon as possible afterwards. So looking at the other side of the balance, if you like, there are some inconvenient truths about these AI scribes. As the RACGP has said, in most instances, the claims of benefit haven't yet been backed up by substantial research evidence. And Te Whatu Ora's National AI and Algorithm Expert Advisory Group has said that they haven't yet been validated as safe and effective for use in healthcare, and the risks and benefits haven't been adequately evaluated in New Zealand. Here's the one that you've already previewed. I'm asking the question as to whether this is a contest between the promised land and where we have as a current reality. And the current reality, the known issues with these scribes are accuracy, consent, privacy, security, data sovereignty, and implementation. And the survey that we undertook earlier in the year, you can see that there's quite a strong mapping there with those known issues. So there's a lot of different platforms on offer at the moment. There's, Nabla and Heidi and so on and so forth, but there's also Tend, and Te Whatu Ora is also got one out there that it's piloting, which John Herries might talk to us a little bit more when the time comes. So what I would say is be very careful not to believe the marketing blurb of the platforms. You should always check the accuracy of the claims, that there's compliance with New Zealand law, and watch out particularly for the changes in the terms and conditions which might occur on the website, and you may not be aware of them. So if we look at some of the marketing claims, we can see Nabla has said that there's claims of about 2 hours per day per provider. And in our survey, 75% agreed that they saved time, 25% were neutral, and approximately 70% actually saved an hour or less. And I think that was because they were spending time checking the outputs, which of course is what we want to be done. And then the other question is, what is the spare time being used for? Is that to see more patients, or is it to give people, the GPs, a little bit of time off out of the very stressful job that they are doing at the moment? In our survey, interestingly, talking about consent, only 58.5% of our participants asked patients before they used these tools for their consent. And a surprising, sorry, I'll just go back up to that one, a surprising about 40% did not. So I think that's those ratios are concerning to me. Sorry about the busyness of this slide. If I'd managed to get the animations working, then this wouldn't be presented like this. But anyway, you can see there are 6 key metrics there to think about in terms of consent. What is the content? Who is consenting? What are the power differentials? The literacy of your patients, whether there's any real choice about whether or not an AI scribe will be used. And probably one of the most controversial is the timing of the consent. So when I go back to the content, it's not just a transcription service, it's actually also summarizing the content of the consultation. And so this is why you need to look at also the terms and conditions of the platform you're using. Is patient data being used to improve the model? Is patient data being sent overseas? And HIPAA and GDPR compliance is not the same as being compliant in the New Zealand legal context. Our survey showed that only 65% of the GPs had actually read the terms and conditions of the platform. If they haven't read the terms and conditions, then they can't properly consent the patients. I think the power differential one is an interesting one in terms of behaviour, and patients may be fearing reprisal, or they might be labelled as a difficult patient. These are just things that we need to be mindful of. Literacy, obviously, I think they're quite useful, some of these generative AI tools, in being able to pitch the consent to a level that is commensurate with the patient's literacy levels. And the timing, I think the current legal preponderance of view is that consent should be sought prior to the consultation. I fully appreciate that there are a number of issues around doing that, practical issues, and it's been good to hear of people putting up posters in the consultation rooms, and also with text messages and so on. So there's a variety of different ways in which this can be affected. So in our survey, there were a significant number of respondents who were concerned about errors and omissions. I'll just leave those examples up there for you to have a look at. These aren't from our survey, but it does show omissions compared to incorrect facts compared to additions, and all quite serious ones. And I heard Carl Cole talking at the last webinar about how bad many of these platforms are at capturing te reo Māori. Our survey showed that 22% were unconcerned, 40% were neutral, and 38% were concerned about that. This is just a quick, a complicated graph showing Hugging Face's analysis of which platforms have the highest hallucination rate. So you can see at the very top of the screen there's a very low hallucination rate there of 1.3%, but going all the way down to nearly a 30% hallucination rate. Heidi does not. I haven't been able to see Heidi appearing on that website, and my understanding is that Heidi uses a mixture of different models, which will make it tricky for you if you want to understand the terms and conditions of the platform that Heidi is delivering. So you might say, well, what's the problems? Humans don't write perfect notes either, but there are things to think about, mostly human-machine interactions. There's automation bias, where you believe what the machine is pumping out for you. There's anchoring bias, where you're more likely to be in the frame of the information that is first provided for you. There are issues around the potential for de-skilling, and as well as having a benefit of reducing cognitive load that these AI scribes have, there's also an issue where some GPs find it very useful to write their own notes because it helps them to arrive at a diagnosis. So this is my last topic, which is about the deployment of these tools. And I was really pleased to hear Carl Cole at the last webinar talking about the need to practice with these. This study from America, the one that I showed before with the different metrics, I think had some excellent pre and post deployment actions. They created a virtual interactive webinar for their clinicians. They had training material. They had educational handouts for patients, and then post implementation, they monitored for safety and quality using that those metrics that I showed you before in that radar plot. A couple of other things to think about in terms of training is if clinicians pause the transcribing. I think it would be useful if there were reasons articulated for why there was a pause in using the platform. Carl mentioned that he is a lot more verbose in his consultations now, so that everything is captured. I think there's also some unanswered questions potentially about how the tape recordings might be legally used. I understand that the Health and Disability Commissioner takes the view that all the transcripts should absolutely be kept. If you're destroying the actual tape recordings, and there have been questions raised about whether you are destroying the ground truth. So lots of legal things to be thinking about. So the key takeaways, I think, are that the scribes are not a replacement. If we follow the advice from the RACGP, they say that they should be used cautiously. The Te Whatu Ora AI expert group recommends using a precautionary approach because of the various risks. I think that the guardrails that we can employ around this is to obtain consent prior to the use, to review and edit the output, to ensure that we have appropriate training programs in place prior to their use, and that we monitor and audit them post deployment. So at the moment, I think I would probably put these tools around about the learner license level, needing constant supervision, not quite even at the restricted level or at the having their full driver's license yet. But I do think it's not likely to be very long until we've moved them from zero to hero, from the Fred Flintstone up to the Liam Lawsons. And I think really the key takeaway, the final message from me is that, yes, let's do innovation, but let's make sure that it's responsible. Thank you.
Kia ora, Rochelle. Awesome. And some great slides in there. Thank you for putting those together for us. And I think you definitely get points for keeping us intrigued with some of those slides and keeping the content really topical, I think, for the people in the audience today. So thank you for setting the tone. Instead of asking a first question to the panel, I'm just going to allow them some time to reflect on anything that you've kind of put out on the floor to open us with today, Rochelle, to contribute to, or to have a whakaaro on. So I'll just go around the screen. We'll let you introduce yourselves, panelists, to the people in the webinar today, and also just share any, I guess, opening whakaaro you have on today's webinar topic. So we might start with you, Sam.
Thanks, Jess. Yes, so my name's Sam King, and I am a very part-time GP. I work with Carl Cole. We've had him on the MPS webinars and podcasts speaking about AI. I personally have been a slow adopter of the technology, but I'm using it now. And I would agree with Rochelle that there are, from not because of hard data that I have, but just anecdotally in terms of the people I meet and the presentations I've given, I would say that not many GPs go through an appropriate consent process, which I think is a risk. And once you get it, I think you need to document that you've got it ahead of your consultation. That said, you know, in reading the terms of agreement, I tried Nabla, didn't find it very good, so I'm using Heidi. I was concerned about Heidi, as a lot of people were, about what's happening to the data. And I think it's really important that everybody does satisfy themselves that what is happening to the data, the security, how long it's kept, and all of those things. That said, I've always thought, just for me personally, that my notes were pretty good. I work for Medical Protection Society, so I'm all over the whole medico-legal risk, and I know that documentation is really key. So I thought my notes are pretty good, but I have to say, Heidi it just blows me out of the ballpark in terms of where my documentation has been. And it changes the nature of the consultation for sure, and I think in a good way. I think that we do need to get ourselves into a different brain space though when we're using AI. And it's all about thinking, is what has been summarized an accurate portrayal of the facts of what we've just heard and what we've done? And everyone does need to be going through and looking at it, because I make changes all the time before I cut and paste it into the notes. Mm-hmm. So I actually think it's good. I think it's actually revolutionary for primary care. And you wonder what people do with that 1 or 2 hours spare, which, to be honest, I can't imagine that's actually the case, that it saves you that length of time. But I can tell you what the GPs will do, and they'll be doing their inbox so they don't have to do it at night for free. And so if you can save time and energy like that, I can say it's a lifesaver for probably a lot of us. And so all told, I actually am for it. That's probably my opening comment. Probably got a few more, but leave it there.
Thanks, Sam. That's awesome. And I think you've opened yourself up for a few follow-up questions as we come around. So that's really great, and awesome to have your opening remarks there. Igna, kia ora, how are you?
So kia ora. My name is Inga. Yes, I work at Massey University. My background is as a GP, and I worked clinically and academically up until about 4 years ago, and then I switched to academic only. And for those of you who don't know me, I tend to do most of my work in and around the management of information technology, digital technology, and data. Yeah, excellent presentation, Rochelle. If I had to grade you, you get an A+. So you'll be glad to know. So there you go. I think you raise a whole series of very important considerations. Probably the one I'd like to add to the conversation is with e-scribes does this raise the question of what is the purpose of creating clinical notes? And do we need to revisit what needs to be retained within clinical notes and for what purpose and in what format? Because to some extent, a simple way to retain it is to just video the entire consultation and retain the video. Is that helpful? Is that useful? Probably not, because we also have a problem of information overload. So how do we deploy tools in a way to make them useful without losing sight of the purpose of creating clinical notes? I would also add that the art of writing helps thinking. And so I'm not sure whether the deployment of scribes, particularly when they may potentially influence the way in which we run our consultations. And I get very worried about technology driving the way we do things rather than looking at how we do things and then fitting that, mapping that across to technology. So who's the driver, the technology or the consultation purposes of the consultation? So yeah, those are probably some of my initial thoughts around it. There's also more tools, I would have to say, than just Nabla and Heidi out there, including some that don't seem to get much publicity, but are probably more appropriate for use within the New Zealand context than those two, particularly the free versions. And that's not talking about John's one that he's developing as well, which will now also go into the mix. So yeah, I think the marketing, as you say, is a problem, that we see what's marketed and then we look at those. I mean, John's team probably has done a sort of a widespread, mapping of what's out there to determine if anything's suitable. But I think we need to publicise the pros and cons of the different systems better to help clinicians choose which systems to use. Thank you.
Beautiful. What great reflections and some good thought-provoking comments to throw into the mix this afternoon. And lastly, John, kia ora.
Kia ora, whānau, ko John here is tokonga no Ngāti Roa no Iahau. My team builds technology stuff in Te Whatuora. And I think, a couple of other thoughts that I'll just throw into here is kind of this perennial conversation about the role of Te Whatuora in the sector. And so obviously, GPs are independent practitioners, but, Te Whatuora is the biggest organisation in the country doing healthcare, albeit not a lot of general practice. And so kind of this interesting thing about what Te Whatuora thinks and what general practice thinks may not be 100% coherent, but kind of often we might be in a position to do some things that general practice finds hard, and so therefore, things we do might have some value to you guys. And I think lots of the stuff has been covered so far. One of the things that kind of occurs to me, probably kind of where Inga was going, is whether we're seeing a change in what this and what the notion of a medical record is with this. So a lot of the thinking we've been doing, kind of which comes out of this, comes from those bright, shiny young people that say, hey, if I was to use one of these tools to read out parts of the existing record as I scroll through the existing record, will it make a summary of that? And the answer is, well, it'll make a summary of everything you say, so yes. And then you ask, why do they do that? And you hit on another problem, which is a little bit of that inbox problem that Sam's talking about, but in a hospital it's kind of CDR blindness, or clinical data repository blindness, where there's hundreds of clinic letters for the patient, and which one do you read first, and do you read them all, and when do you stop reading, kind of some of that kind of question. And part of the thing that we've been trying to figure out is, as a tool, could we be useful in not just summarizing the consultation you're in now, but giving a summary of the previous ones that have been recorded. And so in that, you've kind of got a really interesting question about getting a long way from an AI scribe by literally reusing the technology that you're using. You have the ability to potentially create data items. So we have, make another template which adds stuff to the problem list, or automatically fill out a form for me. So, I've been talking to the ED doctors about making an ACC 45 form from the consultation and filling that out and sending that to ACC automatically. And in all of these kind of use cases, you start to ask this question of, in the health system, we've created a new form every time we've wanted to capture more information, and most of the debate is, well, how much of this is reused information from somewhere else, and or how much of it can we pre-populate? And of course, more forms means more work for everybody. So if you can fill out these forms using the original source, call it that, which is the consultation with the patient, suddenly you're in a really interesting position to fill out any form you want, basically. And yeah, it's only going to be 90% right, but it's certainly better than just filling out the demographics and then having to fill out the rest of the referral form, or having to fill out the rest of the form for MSD, for example, for someone that's going on, a sickness benefit. So there's a whole lot of kind of, I think, really interesting fundamental questions that we've got to talk a lot more about. And that then leads me to this question of third-party tools. and whether really this is something we should be giving up to third-party tools, because I just imagine that it tends to be the way with technology. Anything that you get for free means that you probably aren't the customer. And so the question I've got is, if you're not the customer because you're not paying for it, who is the customer? And, you know, the cynic in me starts to wonder, if you're using a free version of, you know, a tool, maybe the drug company is sponsoring the fact that every time you talk about X medication, it puts their brand on it, regardless of whether you're talking about the generic or not. So you can start to see there's incentives potentially for some of these third parties to want the data and or to influence practice in this, which is not immediately apparent in some of these kind of conversations. So sorry, bit of a rambling, kind of wide variety of things, but
really, really interesting opening thoughts there, and some good philosophical kind of thoughts being thrown around the panel already, and it's only halfway through. But I think it's really interesting and really compelling when we start to, I think in any part of healthcare, start to break down the why. Why do we fill out this form? Why do we do this? What is the process? When we think about it in a healthcare home context, we think about leaning our processes. And when we start to lean some of our processes, we figure out that there's a whole lot of processes that actually don't need to take part in getting the outcome in which we intend to have. So really, really great that that's been brought up in the context of AI, and I think also a really good reminder to ourselves to constantly remind ourselves of what is the problem that this is solving for, and is that the actual answer, or is there a deeper root cause that we could be addressing in this moment in time? So really, really good, thought-provoking corridor. Rochelle, what was your thoughts on John's chat?
Well, I just wanted to pick up on what John and Inga were actually talking about. As a member of the Te Whatu Ora National AI group, we have been had a lot of questions asking to sort of approve a tool or whatever. I should hasten to say that my slides are not, I'm representing myself and not obviously the group. And I think one of the real issues, as well as the ones that John has identified, is that the terms and conditions on these platforms can change. At one point, there was, NABLA said they weren't keeping any data. I went in and had a look and I thought, oh, actually, I think they are. And then it came out that, yes, actually they were. And so then they made that clearer in their terms and conditions. Now, I don't know how many people have got time. Clearly, not everybody's reading the terms and conditions. I think it's really important to know, for example, whether they are keeping the data. Where is it going? If it's going to America, then the Americans have all sorts of interesting powers to take away what the uses for data. And so that raises a lot of Māori data sovereignty issues, which is, as John says, comes back to, do we really want to be using third-party tools where we don't know what the terms and conditions are, that they may or may not constantly be changing? The other thing I've heard from previous webinars, people were saying that they're waiting for the Privacy Commissioner to come out and make some statements around generative AI. The Commissioner has made statements around that. So I just encourage the people who are listening in here to go and have a look at the Privacy Commissioner's website.
Are you able to give us a high-level recap around what that statement is?
Well, basically, to be transparent, to make sure that patients know what is going to be happening with their data. Again, read the terms and conditions before you start using these platforms. And I certainly have heard lots of really positive comments about Heidi, but I think the fact that they mix and match models and things is, for me, I think that's an even higher risk when you don't know what model they're using and what's going on with it.
Yeah, nice. Thank you. Just going to encourage the audience to jump into the Q&A and put your thoughts in there. We've got a few preloaded questions that we're going to quickly nip through. The first one's for you, Sam, and it's around how do we ensure clinicians remain the final decision makers, maintaining their professional judgment and not over relying on AI outputs. And I think you touched on this a little bit in your opening remarks, but I thought maybe you could just go into some good, maybe practical steps that a clinician might be able to take to ensure that AI doesn't become the be all or end all of their practice.
Yeah, sure. Thanks, Jess. I think that AI is simply a tool, and we need to use it as a tool. So it's got its uses, but we need to know what the limitations are. I think it is very important because if we're only talking about using summarizing AI at the moment, reading what it's summarized and correcting it is crucial. At the end of the day, we as clinicians are responsible for the care of our patients, regardless of what tools you've used. And so if there's a mistake in there and you've just cut and pasted the summary without thinking about it, and it's wrong, and something comes of that, it's on us. So I think it's important to remember that you can't blame NABLU, you can't blame Heidi, it's on us. I was reading something, I think it was just this morning in preparation for this webinar, that a number of my colleagues are using AI to help with diagnosis and treatment. I think that there is far greater risk, to be honest, with using that than simply using this for summarizing. It changes the whole nature of the way we think and come to a diagnosis and decide what sort of treatment plan we want. And I think if we remove our clinical brain completely, or our analytical skills, then I think patient harm is more likely to occur. And you can use AI. I mean, for example, if you're going to use AI to suggest differential diagnoses, which is what all the patients do, they come in, they've Googled it, and they'll come in and they say, I've got cancer. And we all roll our eyes. So it's useful if you want to get the breadth of a differential diagnosis. But I think you need to there's a huge step from there to saying it's this diagnosis and I'm going to go down this path. We all as humans have bias, right? And the way that we diagnose, and probably commonly for us, it's a confirmation bias, where we just think, oh yeah, all the evidence supports the diagnosis we've already arrived at. And that obviously often leads us down the wrong path. And how much more so with AI, it's got its own bias. And I think was it you, Rochelle, that talked about automation blindness? How we just have this natural sense of I trust it because it's smarter than me. I don't know about, for example, for anyone who uses Google to get around the place, Google Maps, you can get to one place, but how many of us have followed Google on a roundabout trip thinking this doesn't seem right, but we followed it anyway, only to realize actually Google's gone wrong and we've gone somewhere else. How much more so if we're looking at AI for other things other than just summarizing?
Beautiful. Thanks, Sam. I think there's some really good tips in there for clinicians and anyone using these tools to be able to ensure that they are using it for the purposes and are checking it and going through that space. And I just want to kind of add in there, and I think you touched on this, Rochelle, in your presentation too, is we do have to weigh up with actually not writing any notes. I'm still waiting for my husband's notes from 5 weeks ago, that when he saw his clinician, that still haven't been written by the GP that he saw then. And he'd prefer to have some notes than have no notes. So I think the risks benefits in here, I think, do need to be outweighed. If you've got a workforce that are not able to keep up with the demand or keep up with the workload that they're presented, then how can we support them to ensure that there is kind of a medium hit in the middle there? So I just wanted to kind of add in, I think it's, we've got to think about this in the complete holistic picture of the practice and the well-being of the clinician and the well-being of the practice, and also I guess the long-term benefits and risks that that's going to have associated with the patient as well. Potentially him not having those notes on that consultation, which could have an impact potentially on his future health outcomes and what comes from that. So just being really cognizant of the different benefits and risks associated. Now, Emily's asked us a really awesome question, which kind of links into that, because my husband is also Māori. So what is the impact for Māori thinking about data sovereignty? Can we ethically use any of these platforms for our Māori patients? And I think we've talked about consent, and I don't think that that's any different in this case, but I'll just hand to the panel, and we might just do a quick round in this, because I'm sure everyone's going to have a few things to say. We might start with you, John.
Interesting about the diagnosis stuff. I'll post if I can post a link in the chat or something, I'll post that. There was a paper that recently came out, and it was focused on whether or not humans did better differential diagnosis with or without AI, and consensus was around 75% of the time they did a better 75%. There was consensus at about 75% that the AI and patient kind of made a differential diagnosis, and 74% with the clinician by themselves. And that was kind of the headline finding was, hey, guess what? AI doesn't help a clinician do their work better. What was in the actual conclusion, though, and didn't make the headline findings, was that by itself, the AI was hitting 90%. So it's a really challenging finding, I think, coming out of one study. Needs to be replicated, but you've kind of got this really interesting assumption we make that humans or humans with AI are definitely the best answer, when that might not necessarily be true. In terms of from a Māori perspective, I think there's kind of this question, you raised it yourself, Jess, where your husband hasn't got notes, and there's an interesting question about what it is we might need to do in order to close the gap in an equity context. And I think we're kind of doing a few things in that space. So firstly, understanding tikanga and how that might be applied in a health context is kind of the first part to it. And separately to that, and I think about this in two parts because the way we approach this is kind of two-parted. So first part is, how do you produce good notes in that context? And tikanga kind of informs a bunch of that, and kind of various frameworks that have been created and adopted by the health system over time. But the other part to it, as people have kind of recognised, there's a te reo kind of component to this as well. And no one's going to do that for us, I don't think. So, if you look across to Heidi, is Heidi going to do both of those things? Well, they might end up with a te reo kind of translation if we're lucky. We might for free make it for them, or we might for free incorporate kind of our current organizational practice. But it's highly likely that organizations that work in big countries are likely to train their models based on their data rather than on ours. So if you think about New Zealand being 1/5 or 1/7 the size of Australia, so we're suddenly in a situation where only 1/7 of the data maximum is going to be as consistent as it is with Australia. And guess what AI is trained on? Data. And guess what it waits for? The amount of data that it gets. So yes, it trains a little bit on novelty, but if it keeps getting told that g'day is the right way to open a conversation, that's what it's going to bias towards rather than kia ora. So I think that, to me, is kind of a fundamental thing to think about is I'm not sure any of these companies are doing it for us. And so you've got a really interesting question about, if they're not, who's going to? And I kind of feel like it has to be us that does it. Now, contrast that with actually getting some notes written. And that, to me, is the fundamental dilemma here is it better to have no notes, some notes, or good notes? And that, to me, is kind of a really interesting kind of trade-off. And the whole reason that Sam is the accountable person for writing her notes.
the whole reason. And I think that's a really, really interesting one. And I think, again, it's around bringing that holistic perspective when we're thinking about this with our whānau that we're serving. And I think that goes across all people that come into our practices as well, is just taking that entire kind of holistic picture into the context of the decision making we make as a practice. Having access is really important to whānau and to whānau Māori, and we know that through multiple studies and multiple data collection points across both Aotearoa and internationally, but we know for our Indigenous populations, access is key. And if we're not being able to provide access because we're too caught up in administrative burden, then those are some of the kind of conversations I think are really healthy to be having at your clinical governance meetings within your general practice. Those are the debates that you should be working through, and you should be coming up with solutions for in a really safe and controlled, and I think what Rochelle said, responsible way to ensure that we can get the right outcomes for the people that we're serving. But I'll just quickly open up to Sam, Rochelle, and Igna if they've got anything to add to the kind of data sovereignty perspective.
I could join in, sort of building on the two aspects, one about the availability of notes and whether having any notes is better than no notes. And I suppose my reflection here is it's the wrong question. We should be asking, why are there no notes? And what can we do to ensure that there are notes, whether they are manually written, whether they're using eScribe, whether they're using whatever. And just putting an AI tool in doesn't necessarily mean that we're going to have notes anyway. So I'll just say that and put that aside, that I think it's actually a reflection of a wider problem. And it's part of this thing about are we using technology to solve the right problem, and have we identified the right problem in the first place? With regards to Māori and Pacific Island and what have you, I think, and John's touched on this, the problem we have is that the tools that are being made available are from very large international, multinational corporations. New Zealand has such a tiny share of that market that they are not ever going to, in my belief, design systems for Māori and Pacific Island and other Indigenous populations. Not only are the systems not going to hear those voices, the corporations, I don't think, are terribly interested in hearing those voices anyway. Controversial that may be, but I do think that that is, on an international stage, the voice of Indigenous communities is silent. It's invisible. And I suppose that comes back to not so much a question of should we use these tools or not, but the extent to which the populations themselves engage in the conversation and are involved in the conversation around the use or otherwise of these tools, and not just in the use, but in the whole decision-making process, right back from even pre-design. So, from problem identification right the way through to the design, development, the implementation, the adoption, the evaluation and monitoring and what have you. And so I suppose the question I would pose is, how do we as a country ensure that our Indigenous populations, our Māori voice, is not just heard, but is central to the way in which we choose to adopt and what we adopt and how we use these tools. So I suppose my challenge out there is how do we ensure that through all our decision-making steps that the Māori voice is present and heard. And I know that there are some groups for where we have extensive Māori consultation, Māori engagement, Māori partnership. I think I'd quite like to see somewhere that are Māori-led rather than just Māori engagement. We do run rings. We do have a problem around the extent to which we do for Māori as opposed to with Māori, or how things are done by Māori for the rest of the health sector. So, and I suppose the only other comment I would make, and then I'll shut up totally, is that these systems are designed totally through a Western lens, and they are designed through a corporate lens. They are not designed through alternative viewpoints or worldviews, and that might also be something that we need to think about. Thank you.
Yeah, really beautiful reflections. We are coming to the end of the session today, so I'm just going to ask a few of the questions that have been coming through, but also kind of on our list of things to cover. Otherwise, the AI working group won't be very impressed with me. Sam, we've talked a little bit about consent today, and I think if you could just run us through, what does good consent look like for you? At what point is the patient consenting? And yeah, if you could just maybe do a bit of a role play of how that works for you in your practice.
Sure. I guess because I'm a late adopter, that it's a little easier in that a number of the other doctors are already using AI. In particular, people are most people know who Carl Cole is, and so and most of the patients I see are not my specific patients. I act as more the overflow doctor, so a lot of the consent has already taken place before I see them, because they're aware that their GP would normally use it. But if they're not, I normally talk to them. I explain to them what it is, that there's a recording, that it is a transcription. They transcribe the whole part of the conversation that we have, that and then it summarizes it. And it's the summary that I use, that the data for this particular one that I use is offshore, that it's encrypted as it goes, and the recordings, I read the terms and conditions very recently for the one I use, that the recording's not kept, but that that the data is kept and it is used internally for improvement of the tool itself, but it's not used for it. It's not sold. It's not sent anywhere else. And so I would go through that. And interestingly, for young people, a lot of them are already using AI. They're really familiar with it, and I haven't had anyone say no. For older patients, it's a little different, and I think consent should be layered. Someone said earlier that, you put posters up in your office and things like that, and I think that is best practice if you're only trying to introduce an AI. And so ideally, that's what you would do. You'd send out information before the consultation and all those sorts of things. I guess for me personally, because as I said, I'm a late adopter in our clinic, that a lot of patients are already aware of it. But those are the basic things that I go through. And it doesn't have to take a long time. Most people don't have any questions about it at all.
Yeah, beautiful. Thanks, Sam. And does the practice, or should the practice, have an AI policy? It's something we get asked quite a lot.
Absolutely. Every practice should have a policy around this. The difficulty is that it's very new, and I'm aware that a lot of GPs are using it ad hoc, as opposed to, this is not a clinic decision, this is a personal decision. And as Rochelle said earlier about the Privacy Commissioner's website, there's a 17-page document that he's produced that talks you through all the AI things. You should be doing a privacy impact assessment. You should be discussing how it's going to be used, which ones are appropriate to use. PIA ought to have been done, and before people proceed, and work out what consent looks like in your clinic. And we should all be doing that, because at the end of the day, organisations will be vicariously liable for what their employees are doing. And as all the GPs around know, or all the doctors around know, that there was a significant case that we had the ruling on, which came out of last year, about vicarious liability, and that's really important for clinics to think about their risk. It's not just the individual clinician.
Yeah,
I was just going to say, I think that's an interesting point, Sam, because I ask myself, who is taking the risk and who's making the decision that the risk can be taken? And so if we're talking about access, as Inga pointed out, improving access for Māori, do we tell them, oh, by the way, the tool that we're using is really hopeless at transcribing Te Reo Māori, so I bet that's not mentioned as part of the consenting process. And then, so if it's badly being transcribed, they're taking the risk of the bad transcription, but it's the GP potentially who is making the decision to go ahead and use that. So the AI scribes are not sufficiently embedded in practice yet, although some things in clinical practice, obviously, it's implicit or inferred consent, which is fine. But this is a new technology. The HDC has said that you need to get the consent before you start using it. And so I think when we think about risk and benefit, think out also about who is taking the risk and who's making the decision that that person can take the risk.
Yeah, really good points there, Rochelle. Igna, do you have some thoughts?
Yeah, just a quick add-on, which is that there are an awful lot of studies that show that patients and whānau and communities trust what we as clinicians do with their data. And that it's all very well when things go fine and there's no problems, but it can be really difficult when there is an issue or something goes wrong. It's very easy to lose trust, and we already have that problem with significant parts of our population where they don't particularly trust the health service anymore. So why are they now going to trust what we say in AI? So I suppose my question here around is, how do we maintain trust, not just at a national or international, but actually at a practice level? And what do we do with our practices and our patients to ensure that we demonstrate that we are still a trusted partner in this? Thank you.
John?
There's kind of this sense that this is an all or nothing conversation. It's really interesting. I had a conversation with a paediatrician in Counties Manukau a wee bit ago, and he said, about 30% of my work is dealing with children that I need to assess as part of an oranga tamariki investigation. How are you going to deal with that in this AI tool? And the answer was, we probably shouldn't be using the AI tool in that consultation. And so I think we just need to be clear that, and I think, Sam, you made this kind of pretty evident early on. Hey, start from a place where you are comfortable, understand that this is a new tool, take your time, don't assume that everything has to be done through a tool like this. And, kind of in the conversations I've been having, it's for a lot of hospital clinicians, this is very different to dictation. And so having them understand how different it is to dictation is almost as important as getting them to use the tool. So kind of Rochelle made it really clear that there's a big onboarding kind of process to this, and I think that's kind of something we've got to realize. And sorry, the only comment I'll make about Sam is she's commented a number of times that she's a late adopter. I would say you're still an early adopter given that you're actually using it. So I suppose from a Te Whatu Ora perspective, access to these tools are largely restricted in terms of we've told people not to use them. And so, to me, I feel like we're still on the early part of that kind of hockey stick kind of conversation at this stage. So
I think that it's funny. I never feel like an early adopter, not compared to some of the people I work with, but I think that there will be legislation coming in. They've started it in the EU. They've got an act already, and it'll come in, and there'll be guidelines. I would hope that like the GP college will step in for primary care, that something will come out of the Ministry of Health, and so that there is increased safety in the system. The difficulty is it's such a fast moving, quickly developing area that someone has to be able to keep on top of that, who understands the health sector as well.
Could I just make one quick comment? Cabinet has proactively released a paper which says that they're actually not going to introduce specific legislation around this, that they believe that the current legislative framework is adequate, and that they will essentially, if something kind of goes wrong, then they might step in and do something, which I personally believe is completely the wrong approach. But they've made it very clear that they're not going to follow Europe or Australia or any of the other places that have put in very solid guardrails around this.
Cool.
Yeah, I'm skeptical that any of those are going to be particularly workable from a technology perspective, just because it's in the public. So much of this is in the public domain already, and you can do it yourself in your backyard. I think, if it was hard to do in your backyard, regulation makes it a much stronger proposition. Unfortunately, I think the genie's out of the bottle with some of this stuff. So
yeah, absolutely. So some really interesting and thought-provoking kōrero. I hope that's helpful for you all and it's not more confusing. I think it does provide you some really beautiful things to think about. And I just wanted to preface that some of this stuff is absolutely ridiculous to think you could do in a small or medium-sized general practice. So doing a PIA on every single IT tool that you use in your practice is just unfeasible. So it is leaning into your PHO networks, leaning into other people that will be able to help and support you on this journey and not take the full responsibility of this yourself and lean into the different support networks around. PHOs have been really fundamental in the space of doing some of that PIA work, leaning into supporting with some of the structures and foundations in there, and just wanted to make sure that you feel supported in the way in which you're bringing this into your general practice. So just leaving that there. There was one question in the chat around what training is available. The AI and Primary Care Working Group is going to be releasing some training. So there's a really beautiful guideline that Well South PHO put out earlier in the year. So that's on, if you go onto the GPNZ website, you go into the Our Work, you'll see the AI and Primary Care Working Group page there. And on that page is a link to that Well South document. And that's a really good handbook or guide on all the things that you really need to know about AI in primary care and in general practice. So I would say start with reading that. If you're not a reader and you need to watch some stuff, then you've got the 3-part webinar series to help bring up the education and training in that space. And then for those that love a good online learning module, we're partnering with Hendrix, which is a IT education company based in Auckland, and we'll be working with them over January to build some online content for people in primary care so that they can start to get their heads around how this stuff works. So we are, as a primary care working group, looking at all of those really practical things that might be helpful. If there's something that you think would be helpful that we haven't covered off, do let us know and get in touch. We're really happy to receive that feedback. We will be doing a second survey. So most of you will remember that we surveyed primary care back in July, and we got about 200-300 responses at that point, which was really good around people using these tools. We're going to be repeating that survey towards the end of January, and we really look forward to you sharing that out with your networks and you completing that and trying to get a little bit of a picture around where we're at as a country and as a sector. Obviously there's some bias there that the people using the tool might be more likely to fill it out, but we'll try and get it out far and wide and ensure we can kind of capture some really good thoughts and feedback from there. So there are things out there. I think it's just about taking it all within your stride, taking a bit of a holistic perspective on all the decision making that you're doing and that you're having, thinking about all of the different risks and mitigations that you can apply, and as like any other tool that we're using in a space in general practice in a primary care environment where we do have lots of patient data coming and going, we just take those same cognizant assessments that we're doing through that process. I am going to close us out with karakia. I just want to say have a great Christmas, have a great New Year. My team are on a kind of a shutdown period from the 20th of December through to the 6th of January, and we look forward to welcoming you back in the new year early in January. Huge thank you and mihi to our panelists today for bringing all your wisdom and thoughts and ideas. It's been great having you here. And to the people that have joined us from Practice Land, from PHOs, from primary care, huge mihi to you too. We do appreciate your time in this festive season. I'm going to close this out with karakia and leave you all to enjoy your afternoon. So here we go. Kua wānanga mātou kia whakairia te tapu, kia wātea ai te ara, kia turaki whakataha ai, kia turaki whakataha ai, haumie, huie, tae kie. Ka ki te koutou.